Hello, my name is Per Wulton-Stejan and I'm professor in prosthetic dentistry and CEO of NIOM, the Nordic Institute of Dental Materials. Today we will highlight an important issue for all of you who are going to use translucent zirconium dioxide. I will give the first part of the presentation where I will discuss translucent zirconia in general. And then Mina Sagen, one of my research colleagues here at NIOM, will continue and discuss how to make tooth preparations for translucent zirconium dioxide. We have been using traditional zirconium dioxide since the mid-1990s. And today we have quite a lot of experience from that material. But that material was a core material that you veneered with porcelain, since the core itself didn't have the optical properties mimicking the natural tooth structure. So at that time you needed to make something to make the material look more natural. And for that reason, it was veneered with porcelain. So that meant that in the hand of a very skilled dental technician, you could really make something that looked very natural by combining the two materials, traditional zirconium dioxide in combination with a veneering porcelain. The problem, however, was that the inferior strength of the porcelain compared to the core material made the porcelain the weak link in the material combination. So we saw at that time quite often that we had so-called chip-off fractures. Chip-off fractures that are very superficial, cohesive fractures within the porcelain. Such fractures are of course very annoying, and that is of course something that we would like to avoid as far as possible. Then in 2009, translucent zirconium dioxide came. This was a new option where the zirconium dioxide itself was more translucent, more mimicking the optical properties of the natural tooth. And that made it possible for us to use the material without any porcelain. And that was of course something that was very good, because then we could avoid the very annoying chip-off fractures. So if you look at the traditional zirconium dioxide, the material where you needed to cover it with porcelain, then that was a material that we called 3YTZP, that is 3 mole yttria stabilized tetragonal zirconia polycrystals. So just to have something to compare with, you can say that the ratio strength translucency in this first traditional material was 4 out of 4 in strength, but only 1 out of 4 in translucency. So now in 2009, where we suddenly got translucent zirconium dioxide, it was a new material where the amount of aluminum oxide in the material was decreased, so that we got a little bit more translucency, maybe 2 out of 4, but kept a lot of the strength. So we still had approximately 4 out of 4 in strength and toughness. But then the next generation, 2014, the amount of, or the content of yttria in the material was raised quite a lot. So that we got a very translucent material that was very similar to what we see in lithium disilicate. The problem was that even though we have translucency now 4 out of 4, the strength is only 1 out of 4. So now suddenly strength was a problem. Next generation was the generation that came 2017. Now we have a material with only 4 mole percent yttria, a little bit more moderate, giving us a strength of 3 out of 4 and a translucency 3 out of 4, a little bit moderate, both concerning strength and translucency. So that gave us a material that was possible to use for quite many indications, but still the optical properties wasn't perfect and strength could be better. So to overcome with those shortcomings, there was a new type of zirconium dioxide, and that was the multi-layered zirconia. And multi-layered zirconia combines all the different material groups that we have discussed in one and the same material. So now you had a ratio between strength and translucency that combined several properties of the different materials, but they varied with the crystal content within the material, and that is very brand dependent. So it depends on what brand you look at. But now we have a possibility to combine the different properties and getting the best out of what material we choose. So let's stop now a little bit and go back and look at the properties of the traditional zirconium dioxide. If you compare zirconium dioxide with other ceramics, as for instance aluminum oxide, you will see a property that is very, very suitable and makes zirconium dioxide useful for heavy load reconstructions in the oral cavity. Take a look at this picture. This is what happens when you press a pyramid-shaped diamond into the surface of aluminum oxide. You will get a crushed surface in the center, and then you will see crack formations emanating from the corners of the diamond and developing without any stop. If you compare that treatment with what happens with the same treatment of zirconium dioxide, you can see that you actually in the surface of the material you get a perfect impression of the diamond, almost what you could expect if you have done the same to a metal or an alloy. But you can also see that there are short fractures in the corner of the pyramid. And those short fractures, they just started and then they stopped because the material is tough. And that is the toughness that is so typical for traditional zirconium dioxide. So this mechanism that makes the material as tough as it is dependent on the tetragonal crystals within the material. When a crack starts to grow, in the crack tip area, the tetragonal crystals, they transforms to monoclinic ones. And the monoclinic ones is a little bit larger, and they will create a compression area in front of the crack tip, and that will stop the crack from growing. That is the toughness that we see in traditional zirconium dioxide. And this high toughness is related to the tetragonal crystals within the material. This is what we see in 3 mole% yttria stabilized zirconium dioxide. Now, when you increase the content of yttria, then you get another type of crystals within the zirconium dioxide, and that is towards the cubic crystal. And the cubic crystal have more translucent properties compared to the tetragonal ones. The problem is that those crystals, they can't transform to monoclinic ones, so you lose the toughness that you saw in traditional zirconium dioxide. So while we increase the translucency, the toughness decreases. And that's the reason why we often use multi-layered material, because with multi-layered material we can use all the types of zirconium dioxide that we like within one and the same material. And if you look at this disc, that is a disc that can be used for milling reconstructions, you can see that there are different layers with different strength. You go from layer 1 with low strength, that means high translucency. And then you go down into the material and you see you go towards the 5th layer that is very strong. That is as strong as traditional zirconium-dioxide, but of course without the translucency properties that we see in layer 1. In this way, we combined the best out of two worlds. We have a material with translucency where we need aesthetics, and with strength where we need strength. At least that is the idea. So what do we know about those materials? There are some clinical studies published. There are some ongoing clinical studies, but still we must say that we don't have the long-term clinical studies that we need. So to be really sure about the properties, we need to have more clinical studies. And they are ongoing, but they are not published yet. So we have to wait a little bit more. If you look at the laboratory studies, the lab studies, we can say that the material properties are very promising, and the results from lab studies are very promising, but we still need to wait for clinical results. So what about if we have a case where we would like to have a strong reconstruction and we need to pick a material that is less translucent just because we need the strength? Then there is a possibility to combine in the traditional way porcelain with zirconium-dioxide without having the porcelain in the occlusal surface of a reconstruction. So we combined porcelain again with zirconium-dioxide, but this time we don't have any porcelain in the load-bearing areas, just in the buccal areas where we need the aesthetics. And when we do that, we need, of course, to adjust our preparation. So we add space for the porcelain in the buccal area. And you can see on this picture that there is a deep chamfer in the buccal area, and that is to add space for this extra porcelain. And Mina will talk a little bit more about that. This is a semi-monolithic reconstruction that we made some years ago, and if you look at this picture, the only thing you see in this view is actually porcelain, because the porcelain is covering the zirconium-dioxide. But if you look from the occlusal view, you can see that the occlusal surfaces, they are made completely out of zirconium-dioxide, and you can see the margin between the porcelain, the buccal porcelain, and the occlusal surface. This is a way to combine the best properties of both materials, both the porcelain and the zirconium-dioxide, where you use the porcelain for the aesthetics and zirconium-dioxide to get strength. One thing that is important to remember, to be aware of, is that the shape of a ceramic reconstruction is very important for getting strength and durability. And if you look at the picture on the left-hand side, you can see that the green area, that is the core material, the shape of the core material. It is a very smooth connection between the two units. And that is something that gives a reconstruction strength. On the right-hand side, you can see a monolithic reconstruction, and you can see that the separations between the different units that you need for aesthetics that makes the reconstruction look like separate teeth. It is very sharp within the core material, and that makes something that could be a fractural impression and start points for crack formations, and that lowers the strength. This shape lowers the strength of the reconstruction. So if you look at the difference between a smoothly shaped separation and a sharp separation between two different units. You can see that the load-bearing capacity when you have a smooth intersection is much higher compared to when you have a sharp separation between the different units. So one should be aware that sharp separation is very detrimental for strength of a reconstruction. And it's sometimes better to make a really well-dimensioned connection with smooth interproximal separations so that you avoid crack formations in these areas. Another thing to be aware of is that the preparation that you do plays an important role, because if you have well-dimensioned, well-shaped interproximal areas, but you have made a preparation with, for instance, a slice, then the slice will not allow for dimensions in the cervical area of a crown. And that means that when the crown is milled or the abutment is milled, then you will get finish lines that is very, very, very under-dimensioned. And that will make a weak point when the reconstruction is subjected to load. And you will see crack formations emanating from the cervical areas, especially floors that you can see if you try to mill something very, very thin. And those floors, they act as fractal impressions, and you will get a fracture from this area. So this is very important. And this is actually decided by the dentist making the preparation. So you should always use chamfer preparation, never ever slice preparations for a reconstruction like this. And just to show how important the cervical area is, you can see on this slide that where you have the red arrows, the longest red arrows on the left-hand side, and maybe the red areas on the right-hand side in those two colorful pictures, that is the areas where you have the highest stress formation. And with stress formations in combination with thin margins, you will get crack formations emanating from the cervical area and propagating through a crown or maybe a bridge, and then you will have a fatal fracture. So, when the need of strength make the mechanical properties of ultra-translucent zirconium-dioxide insufficient, for instance, when you have 5Y to 7Y zirconium-dioxide, that is the mold percentage of yttria, what should you do? Well, you need to be aware that when you increase the translucency, you lower the toughness. And that means that the preparations that you are going to make for a crown or a fixed dental prosthesis need to be adapted to the material you are going to use. You can't use the same preparation technique for 3Y zirconia or 5Y zirconia because the properties are different. And that is something that my colleague, Dr. Mina Sagan, who is a researcher here at NIOM, is going to discuss now. So I welcome Mina to take over.
Thank you for your presentation and the introduction, Per. I will now take you through tooth preparation for translucent zirconia. With all the different zirconia materials on the market, we have to know how to prepare our abutments because the space or the reduction needed is directly related to the material or material combination that is going to be used. A bilayered zirconia restoration demands a larger substance removal to create enough space for both the core and the veneering porcelain. Today, the veneering porcelain is mostly limited to the buccal surface, reducing the need for extensive substance removal on other surfaces of the abutment. With monolithic restorations, the space needed for sufficient thickness is directly connected to the type of zirconia used, meaning the amount of ytria added. If we are preparing for a fixed partial denture, we must make sure to have enough space for sufficient dimension in the connector area to avoid material fractures. When we have decided to use zirconia as a restoration material, we must always prepare the abutment with a chamfer preparation. With a correct chamfer preparation, the dimension of zirconia at the finish line is large enough to withstand the tensile forces that the restoration is exposed to. Also, too thin restoration margins are prone to cracks during milling, resulting in sites for further crack propagation and smaller or larger fractures. Different zirconia materials have different demands for minimum substance removal or space needed for the correct dimension of the restoration. For translucent zirconia with 4 to 7 mol% ytria, the minimum space needed for anterior crowns is 0.8 millimeters, while for posterior crowns, the dimension should be minimum 1 millimeters on all surfaces. For less translucent zirconia with only 3 mol% ytria, the substance removal is lower. Anterior crowns must have a dimension of minimum 0.4 millimeters, while for posterior crowns, the minimum dimension is 0.5 millimeters. But one must remember that this is for monolithic restorations. If veneering porcelain is needed, the substance removal must be increased with 0.5 to 1 millimeter on the relevant surface. Another factor that affects the substance removal is the masking ability of the material. Abutments may be discolored for many reasons. Regardless, we want to mask the discoloration. As we have heard, the amount of ytria added to zirconia affects its translucency. We can see from the pictures here that 5.5 mol% ytria added to zirconia results in about the same translucency as lithium disilicate glass ceramic. But with lower amounts of ytria, the translucency is strongly reduced. We can also see that when the thickness of the material is increased, the translucency is reduced. This means that when we want to restore discolored abutments with indirect restorations, we must adapt the substance removal or maybe select a material with lower translucency. In our communication with the dental technician, we must always inform about the abutment color. This is to ensure selection of the appropriate material. Using an abutment color scale is very helpful in the communication with the dental technician. In this clinical case, 2 abutments were prepared for a fixed partial denture. The buccal surface of 4-3 was prepared with a deep chamfer to have enough space for a veneering porcelain layer, while 4-5 was only prepared with a shallow chamfer because there was no need for veneering porcelain on this abutment. Some preparation designs must be avoided to reduce stress on the restoration during cementation and function. It is also challenging for the milling burr to mill crowns with these internal designs, which results in misfits and large cement gaps. A finish line with a J shape or a reversed margin is difficult both for the scanner to read and for the milling burr to mill. Also, the tooth substance at the margin will be fragile. A shoulder preparation must be avoided since a 90-degree angle cannot be milled by the milling burr, and also cement evacuation during cementation is affected with this design. As both Per and I have said, a slice preparation should not be used with zirconia, since the margins will be too thin to withstand the tensile forces during loading. And also during milling, a thin margin is prone to cracks and fractures. As for all fixed indirect restorations, undercuts on the abutment makes it difficult to place the restoration. There is a risk of over-milling to compensate for the undercut, resulting in thicker cement gap and also a weaker restoration. If we finish our preparation with a rough margin, the adaptation of the restoration to the finish line will be poor and also serve as crack initiating areas. If we have two parallel axes on our abutments, tensile forces are induced on the restoration, leading to fractures of brittle materials like this, and also furrows and grooves on the abutment must be avoided, since the milling burr is not able to mill the internal design of these restorations. And as we know, ceramics, we must avoid sharp edges. It's both due to the ability of the milling equipment, but also sharp edges serve as crack initiating areas which might result in fractures. As I've been saying, there are limitations to the milling equipment and shape of the milling burr. Some internal designs of the restorations are impossible for the milling burr to mill, which might result in over-milling and misfits. We must have this in mind when we prepare our abutments, so we make sure that we perform a preparation that the milling burr will be able to mill out the internal design of the crown. One of the newest products on the market is zirconia veneers with only 0.2 millimeters thickness. It demands almost no preparation of the abutment. But there are some concerns regarding these type of restorations, because as I have been saying, a chamfer preparation is highly recommended for zirconia restorations to have a sufficient strength to withstand tensile forces and also avoid cracks arising during milling. If we take a look at the restoration with the red arrow, we can see a crack in the margin, which is most likely a result of milling of such a thin zirconia restoration. This crack serves as a potential site for further crack propagation and smaller or larger fractures. Also, with such high translucency in the material, which is needed for veneers, the strength is low, probably not much higher than for glass ceramics. And when we also know that the bond between resin cement and zirconia is unstable, the indication for zirconia veneers is not so clear, or maybe other materials are better options.
Hi, I'm Dr. Tove Brubak and I'm responsible for NIOM's courses. If you found this webinar interesting and you would like to learn more about dental ceramics, we have tailor-made course on the topic. We also have other interesting and specialized courses on different topics, which you can find on NIOM's homepage, niom.no/courses. Please do not hesitate to contact us on any inquiry you may have. Thank you so much for watching.